Now, on Thursdays, we like to have conversations that also touch on matters of health. And today, we want to raise an issue that for the next 2 hours, we want to have a national conversation. And the national conversation here is what happens when you feel unwell. You naturally are told by someone, "Uende kwa daktari." So you go to a daktari, and then you come out of there and you're told, this is what we think is wrong. This is a diagnosis, and this is a course of treatment. Whether it's saying hospitalization, admission, or prescription of medication, or other forms of treatment. And then people will tell you, and you're still feeling this way. Maybe you need a second opinion. This has become commonplace for very many cases that people will always be told, you need a second opinion to what you've heard. Why do we get to that level of second opinion? And in many cases, you'll find that a second opinion does not go with the first opinion, or a second opinion does not go with the third and fourth opinion. What happens to these cases of diagnosis? What is it about our health sector? And that's why medical misdiagnosis is our conversation. For this first hour, we want to talk to the president of the Kenya Medical Association, Dr. Simon Kigondu. We'll also pick some of your calls. But for the second hour, that's 9 to 10, we want to hear your experiences as well with issues of medical misdiagnosis, with issues of just medical concerns. And maybe the president of the Kenya Medical Association will respond to them. Dr. Simon Kigondu, good morning.
Good morning.
Thank you very much
for having me.
Thank you for joining us today.
Yeah.
And we hope to have, a good, incisive conversation, just seeking to understand how our health system is structured and how the professionals in the health system work. But first, Janet will give you the day's quote.
I will. I hope I don't forget to read something that Stephen Kosira has said here of when you elect hyenas to look after goats, then you shouldn't be surprised when the goats are eaten. Wait, we'll circle back. Today's quote is by Buddha, the founder of Buddhism, the spiritual leader from many years ago. 3 things can not be long hidden: the sun, the moon, and the truth. You agree? 3 things cannot be long hidden: the sun, the moon, and the truth.
As a gynecologist,
as an OB/GYN,
pregnancy.
We actually added that. The second hour, somebody had commented and said, Janet, ongeza hapo ball.
Oh,
Right.
I knew as an OB/GYN.
It'll be like always a feature. But there's-
So add it.
unless it's I think it's an ectopic, the one that can't be seen. So it's possible.
It's possible.
Yeah.
In rare
Yeah.
cases, but it's possible.
so you bring in an important aspect to that saying, time. Yeah. So the time was not specified.
Okay.
So as in by 9 months, we
Definitely.
you will have seen. But I like that saying that you have brought, and part of what we as Kenya Medical Association, which is the umbrella organization for all doctors in the country, do is, despite challenges, let's say, despite whatever is happening, Kenyans have this fait accompli kind of thing. Imefanyika, itafanyika, you have no say about it. So what we normally do in terms of truth, we put it out there. So that in 1 year, in 5 years, in 10 years, the truth will be out there. So that I will quote, I'll say, but I told you so. So truth eventually is a matter of time, and it's normally a victim of current circumstances, you see. So that's the way we look at it. So the sun, the moon, the truth, and pregnancy.
There was an entire show called I Didn't Know I Was Pregnant. Let me tell you, sometimes, people were saying I felt a pain, I went to the emergency room, and then I'm being told I'm in labor.
Yeah.
There's a lady who gave birth on a train over the toilet.
Yeah.
She didn't know she was pregnant.
So hapo kwa end pregnancy,
How does that happen?
50-50.
No, but by the time she gave birth, then the truth has come out. She
Yeah.
was pregnant. I mean, you
After
get
the
about
fact.
No. At the time. How does what happen? Yes.
How does the I didn't know I was pregnant happen?
How does one go for that long?
No, it can happen, especially if you're a first-time mother. A lot of first-time mothers don't know many things, so that's possible.
Have you faced that?
Yeah, many times. That's common.
And she wasn't showing, right? Sometimes they're not
No,
showing.
the first ones don't show. You know, they've been doing sit-ups, abs. Abs are tight. So first pregnancy may actually not show. There's a father who went to take the daughter for pain. And the doctor came out and told him, congratulations, you're a grandfather. So it happens.
Wow.
It does.
Yeah.
Wow.
Watch that show. It's wild. Every episode. Some were clubbing. They were in the toilet. They felt some type of way. A baby came out.
My goodness.
Yes.
Yeah.
Yeah.
I know. And you
Sherehe
move on. Daktari, so you've told us briefly that the Kenya Medical Association is the umbrella body for all health professionals or just all doctors?
So, as constituted, the Kenya Medical Association is a voluntary, professional association for medical doctors, which has associate membership of other health professionals. So can you be a nurse and a member of KMA? You can, but you don't have voting rights. So you have all other benefits other than voting rights. So as constituted, it is constituted for medical doctors. Yeah.
Okay. And it's just an association. And where you deal with welfare of doctors? Or what else do you deal with?
The twin mission of the Kenya Medical Association is one, welfare of its members, so not necessarily doctors, and two, more importantly, advocating for the highest quality of healthcare for all.
The advocacy bit.
Yes.
Who regulates the health sector in Kenya?
Very good. That actually, it's very important, and I can't live here without giving the big picture so that even as the media reports, then you have given the context. So, at the top, the political body in charge of healthcare in Kenya is the Ministry of Health. In a devolved county system, you have national government and county government. So the county governments would have ministries of health within their own, and the national government would have that role. When they devolved, they mainly left the policy issues at a national level, so that the Ministry of Health gives the policy, and the counties receive the policies and domesticate. So what you are saying, you are given a blueprint, and then you domesticate it. At the level of regulation, you have what is called regulation. Then you have regulation of the health sector is for facilities and for individuals. Yeah. So for facilities, the body charged with facility regulation, meaning that they give you a license to practice, is the Kenya Medical Practitioners and Dentist Council. Yeah. That's for all facilities. Yeah.
And by facility here, what do we mean?
Health centers, dispensaries, hospitals, and hospitals, yeah.
Okay.
All health facilities, in short.
Okay.
Any facility that is offering a medical, some medical service.
Minus pharmacies.
Yes. So pharmacists are now regulated by the Pharmacy and Poisons Board. You get, so mainly a pharmacy, you're dealing mainly with products and professionals.
Okay.
So you have facilities. Then at the level of the individual, then you have licensing bodies. So for you as a doctor, who allows you, and licenses are normally yearly, having fulfilled some qualifications, who allows you, who gives you a license to practice? So for doctors, dentists, is the Kenya Medical Practitioners and Dentist Council. For clinical officers is the Clinical Officers Council. For nurses, you have the Nursing Council. Yeah. Then so you have some the older sort of professionals have a law that governs them. So you have the KMPDC Act, you have the Nursing Act, you have the COC Act. Now, for those, over time, we've realized that there are some unregulated professionals, meaning that they don't have a body that is licensing. So a lot of them, you gang up together and you want to go towards having a body, but as it stands, KHPOA, Kenya Health Professionals Oversight Authority, has taken up that role of actually accrediting the other professionals until as of if they can get their own CAP, like a CAP in chapter, a law.
Who are the other professionals here?
Other health is complex. Health is very complex. So, and it's an orchestra. So the outcome does not depend on one cadre, so to speak. So you can, if we use, for instance, just to go maybe list other professionals, you see, you may have a broken bone, then now you've been fixed, then you are sent for physiotherapy. So you see, that's a physiotherapist. Then you can have birth asphyxia. You're born with difficulties for whatever, oxygen is, and you have problems, and then you need to be sent to an occupational therapist, meaning that you could, or a speech therapist, you know, your speech has gone for whatever reason. So all along the line, everyone that serves towards making you well, or your recovery and all, is in the health profession. So for instance, you could have a very good fixation of your bone, you know, but the physio, you don't go for physiotherapy. You'll still have maybe your contracture, you know, labda ikae, but why? Because, but lakini, some people may blame, for instance, the orthopedic and say, oh, you didn't do a good job. But when you look at the whole structure, then, so there are very many professionals, including biomedical engineers, for instance. You get the guys who fix, for instance, if the anesthesia machine is not delivering oxygen, then the surgeon goes in, does an operation, then you die. Of course, the first thing, you can't kill the doctor. You get what I mean? But, you know, if you survey, was everything in place? You get what I mean? So health is an orchestra. It really needs to be assessed like that.
I like, that's a really good way of putting it, that it's an orchestra, so there's many parts that are played. I want to move us to the reason why you're here in this conversation. And maybe we can start by what is diagnosis and what is misdiagnosis. And then it affects, what, about 30% of patients, it seems, especially around HIV, TB, H. pylori. Curious about that. But yeah, misdiagnosis versus misdiagnosis. Maybe you can demystify that.
Okay. When you're seeking a health service, suppose, then the picture is very clear. You have gone with a problem and you have gone to a professional. Then at the end of the day, you want that the professional has been able, using all the available resources, to say that you have this condition. This is the treatment, then we send you and you get the treatment, and eventually you get better. You get, so So there are various, now in between there are various gray areas. You may have, and if you go directly to a diagnosis, if you get the diagnosis wrong, and this is the principle of medicine, you can only treat what you have diagnosed correctly. I'll give you a simple example, malaria. If the mosquito, female Anopheles mosquito, bites you, it starts circulating, multiplying in your arms, then you'll start having constitutional symptoms of a disease called malaria, which means that the symptoms you are getting are as a result of the circulating malaria parasite in your body. So one of them will be a headache. So if you go to someone and they say your headache is maybe because you have a flu, and then you are given flu medicine, you may end up dead from the malaria, because the natural progression of the malaria is to kill you. You get what I mean? Meaning that it gets worse, goes to liver failure, goes to, you get. But if you give the anti-malarial, for instance, it's dramatic. You get what I mean? You have eliminated the circulating malaria, let's say, and you've gotten better. You see, and you've solved all other problems. So malaria was giving you headache, maybe diarrhea or something. You've killed all but you could take the other approach where you're treating the headache, Panadol. You're treating the diarrhea, you treat. But eventually now you haven't addressed what is the cause of the problem. So that can be called a misdiagnosis. Yeah, you could also be given, they could diagnose the right thing and give you the wrong drugs. You get, so that's another one called a pharmaceutical error. You get my point?
Yeah, I do. So some people might argue, you're doctors, you know medicine, you understand. Maybe it's to just try and understand how misdiagnosis comes about, given that the faith is in the practitioner who knows what to identify and then knows what medication to give me. I think recently when I was really unwell, and it felt COVID-like, so I was running a high fever and everything. Then a few days later, because the symptoms hadn't subsided, and I'm like, I don't know what this is. The doctor told me, you're okay, you're not showing anything, but I was feeling sick. And so another doctor told me you have what's called a low-grade fever. So that was a bit, I went back and forth because I'm like, okay, because I feel like I'm falling apart.
I'm not feeling okay.
I'm feeling really bad to a point where they were even like pushing me in a wheelchair because I couldn't walk. Somebody's telling me, but you're fine. Your symptoms are not showing. Somebody else says, oh, it's low grade, it'll be fine. And I asked him, is this a case of misdiagnosis? Because I feel like I've been, gaslight is a big word. But that just came to me because it was as recent as March. And I remember feeling so frustrated. So going back, there was a rant with a question. So going back to, we have faith in the practitioners, they should be able to identify it. So what could cause a misdiagnosis? Because people listening and watching could be like, no, that's unfair, doctors should know their jobs. Maybe there's another reason that we don't see from your perspective.
Yeah, so that's a very good way of putting it, and always when you give the real life example, it's easier to illustrate than the policy brief that we sort of give. So that's why we come to these shows to put it in light. Now, a disease can actually be evolving, you see. So time, from your saying, what you're saying, time, you know, the truth eventually comes out. And it is possible for you to actually go and then 3 days later you say, this is malaria. Let me use malaria as a very simple example. The incubation period, so to speak, is the time between when the mosquito bites you and gives you malaria to the time you start displaying symptoms. You get? So between that period, you may start feeling funny, bad, but maybe, you know, the picture has not fully evolved. So any diagnosis in between here may not necessarily then eventually say, so what's the diagnosis of malaria? You take a blood slide and you see the parasite, you get? But there's a period at which there is no parasite, it's not visible. You can even use HIV as a very good example. There's a part called window period, a very dangerous part where you have HIV circulating and multiplying very fast in your body, but you don't know. So you go to the lab, for instance, they do a HIV test and they say you're negative. They are correct, but they are wrong. Are you getting the point? So you will say, oh, I came here, I had HIV. They didn't go, so that is the problem. But we can still now go to the other issue, and maybe what we need to target is something called a medical or a treatment error. Error. A mistake from medical or treatment, so medical errors. So Kenya Medical Association is a member of the World Medical Association. And to go even further, this year in Porto, on October 8th to 12th, we will be inaugurating the nominee of Kenya Medical Association to the World Medical Association as president. Dr. Jacqueline Kitulu. So we welcome all of you, and we really would like coverage of the inauguration October during the World Medical Association General Assembly. Why do I say that?
She's a past president of KMA.
Yes. So Dr. Jacqueline Kitulu was the first female president of Kenya Medical Association. It used to be a boys' club a long time, between 2016 and 2020. And therefore, we fronted her because of her a lot of experience in a lot of both the national and international issues. Now, why is that important? The WMA, when we attended the 73rd WMA General Assembly in Berlin, Germany, October, we attended. I was there. Let's put it that way. We revised the policy on medical errors. So if you read around, the WMA has policies on everything. Anything that is complained for about is there. So the first policy had been adopted in 2002 in Washington. The second one, then the other one in 2012. You know, they keep modifying as technology increases. You have to keep, you know, there was no AI in 1990. So the policy keeps better. And the latest update, which the association contributed to, was the WMA General Assembly of Berlin, which we attended. So just to read a bit of it, the preamble is that, and for me this is most important, physicians strive to provide safe, high-quality health and medical care to patients. So what we normally say, of course we are hit a lot and we accept maybe there was an error. No one wakes up to go and kill someone. You get, no one wakes up to go and misdiagnose you. No one wakes up to commit a medical error. That does not mean that a medical error cannot happen. You get what I mean? So a lot of progress has been made in medical science, which has transformed how modern medicine is delivered in advanced and complex health systems. And it's important to know that health systems are actually complex, and this is important. Inherent risks always exist in clinical practice. Developments in modern medicine often reduce that risk, but may also introduce new or increased risks, some of which are avoidable. On that statement, I'll give you an example. When we as gynecologists are following up a mother who is in labor, you get, there are various ways of listening, ensuring the baby status is fine. When you go to the high-end hospital, you'll find a machine called a cardiotocograph. It's a machine that listens to the heartbeat of the baby and looks at the contractions and matches the two. And if you see some funny reading, then you may intervene early. Out there is no cardiotocograph. We listen, I don't know whether anyone has experience of that fetoscope, the one that you get what I mean. So fetoscope, it's intermittent, you listen and go after 15 minutes. A cardiotogram can give you a reading. So if an error occurs, for instance, in when you're listening to a baby fetoscope, maybe the baby just dies for whatever reason, then just to compare directly, a cardiotocograph maybe would have picked that 1 hour earlier and intervened maybe by a cesarean section. But that intermittent, for instance, may not. So this difference in the equipment then is important.
It plays a role.
You get it, plays a role. So physicians and healthcare organizations, therefore, should attempt to foresee these risks, you get, and manage them to the best of their abilities.
Okay. I'll have you pause there just so we can take a break. But when we get back, and it's good that we've set the scene on what misdiagnosis is and, you know, what the policy looks like from the World Medical Association, who is in charge of policy, who's in charge of implementation. Then now let's go into the actual, you know, nit and grit, if that's a word. What are the most prevalent cases of misdiagnosis? How do our rates of misdiagnosis compare to the global average? What interventions can be made from a patient perspective, from a policy perspective, from a doctor perspective? We'll go into all of that in just a minute. If you have any questions, hashtag is Fixing the Nation NTV. Of course, you can also call in on 0719-038-858. We'll be right back with Dr. after this. Diagnosis. Like I said, you had set the stage for us, but I wanted to now know in Kenya what our rates are. We spoke to 30%, which is what you get from most data online. The most prevalent cases being HIV, TB, H. pylori. What else had I
Is
seen?
malaria also in that list? Because there's misdiagnosis of malaria
Right.
also.
Okay, yeah.
But yeah, you were
So yeah,
listed.
what is the prevalence of medical misdiagnosis? What are the most commonly misdiagnosed diseases, and where does Kenya lie compared to global rates of misdiagnosis?
Yeah. So it's important. I'm sure the list or whoever has done a study, we would really need to see the study methodology and all to really say. So we cannot say, oh, the rates of
there was one
medical.
from the Kenya National Union of Medical Laboratory Officers raised concern over high levels of misdiagnosis. It cited 3 out of 10 patients in the country get the wrong diagnosis or treatment.
Yeah. So as a country, it's important to do research, collect information, so that when you are quoting 3 out of 10, you're telling us, a research done and the methodology, so that we prove. What we can acknowledge is that medical errors or misdiagnosis, if you put it, do occur. Yeah. So, and you really cannot say, oh, these are the most common. I'll give you a very simple example, again, going into my line of obstetrics and gynecology. An expectant mother can come complaining of acidity, you know, kahasho and all, you know, for a long time. So they come, they're given antacids, and then as they proceed, then later, depending on which facility, again, you're going, who is seeing you, then later you find that they have convulsed. You get what I mean? Yeah. So one, as we were in medical school, one of the most misdiagnosed is preeclampsia, you know, hypertension. And then, so they are getting pain because the liver is starting the capsule, you know, there's some bleeding in the liver. So, but it's in the same area as acidity. So you kept giving. So someone without that knowledge would actually treat for acidity. And then now you'd eventually know that it is preeclampsia, hypertension with liver problems, once now it is far-reached. And that's one of the essences of antenatal care, where you're trying to pick these things early so that you prevent the progression of that. So practically anything can be misdiagnosed. I have a relative whose diagnosis took 6 months. They come repeated, maybe they get some illness, then eventually, in fact, the doctor was telling us, just hold on, you know, they start taking some tests, and then eventually a diagnosis is made, and once a diagnosis is made, they say, how did we not see that? But it's a process. You get the problem.
But for some people, so how do you gauge or hold those two truths of it's a process, but I'm also really sick? You know what I mean? Or I know what I'm feeling.
Yeah.
I hear what you're saying, though, as, you know, some of this just needs a day or 2 or 3. But as the patient, I'm sure there's an impatience to figure out what's wrong. Before we even go deeper into misdiagnosis, what are patients supposed to do? How do you relay that to patients to say, Veru di kesho kutwa, tumia Panadol for now, and then come back in 2-3 days?
Yeah. So medical errors or delay in diagnosing can be graded from 3 areas. 1, the patient, the provider, and the system. You get? We have patients who don't give us complete information. You see, so when something goes wrong, then they say, oh, the doctor did not, or for whatever reason, maybe the truth has come out. I will not use gynecological examples, yeah? So, and how do you take that down? Medical providers are asked to take very good medical documentation, so that when we are going through that complaint of yours, for instance, we say that we saw you complained of headache, needing, and all that is written down. You get, so that an independent person can actually review that and say, hey, by the way, and we do that. Sometimes say, hey, you see, she complained of this, maybe this was missed. So one of the ways that medical associations, like Kenya Medical Association would do, is to help in that process by doing what is called a peer review. You get, so your fellow doctor is the one improving the system by saying, that, yes, by going through the notes. And that happens, for instance, when a complaint is lodged, the first thing the medical council is asked is, bring us the notes. And that's why it is very important for medical professionals to document everything. You know, some things are said that don't look important and not written, maybe, yeah. So maybe that comes with experience. Maybe the older doctors may be more experienced than the younger ones, but complete documentation has become important in that. The second one is the provider. There are various factors. If I'm seeing you as the 30th patient in a busy public hospital, you get, whereas you are 100% of yourself, yeah, this is tired, fatigued, maybe he's not seeing anything, he wants to push the queue, and that could work. So there are provider factors. If they don't have knowledge, you know, they haven't reached the knowledge, and that's why there is a specialist. Sometimes you refer, hey, this thing we have tried to find out what it is, but we refer to the specialist, subspecialist, you get, because there are some illnesses that you may not need. Those are provider factors. So at the end of the day, the provider must be optimum, very well skilled, first the correct, you know, sometimes you complain about they are not doctors, mnasema ni doctor or a health provider, but it's not, maybe it's someone in the streets with a white coat, a quack, actually, I didn't want to use that word, but yeah. You see, so you must get it right. So the person is skilled, has knowledge, and the third one is the healthcare systems. You get, I usually give a very good example. In 2017, KMPDU launched the 100-day strike. And politically, the government will come and say, will tell the public, you see, you're dying because your doctors are not in the hospital. You get, but I say this now. What normally, and I love doctors because they don't only protest for their salaries, they protest for the health system. You get what I mean? So what are they saying? I'll give you a very simple example. I'm working in this hospital X, where you have gotten a heart attack, let's say, yeah? And you come to this public hospital, and the doctor is present. He actually diagnoses a heart attack and prescribes anti-heart attack drug, which is not there because procurement, they have eaten all the money, they haven't procured. We have been complaining about this drug, yeah? The patient dies. What will the public say? Janet will not complain. She said, huyu mgonjwa alikuwa mgonjwa.
Alienda kwa ile hospitali.
She won't say that. Alikuwa mgonjwa. They know. They saw her having collapse, and they'll say, but what? The cause of death through a peer mechanism, which is normally can only be done by is lack of drug X. Is not the hospital, is not, you see. But the government having, or not necessarily government, whoever is in charge of getting those things, labda pesa imekuliwa, will not be blamed. They'll not be seen as the cause of death, you see. And that can only be done, it can only be brought out by an independent review process, what we normally call audit. You get what I mean? You audit the system.
After the fact.
Okay. So now, when these public guys complain, we are losing patients because these guys have refused to buy drugs, then they go on strike. You get, and now you're forced to go to the public, private, let's say, a private facility, let's say. When you go to the private hospital with your heart attack, drug X is given and you go back home, you see. Right. Because the drug is there. Because now you are paying, you see. So that's the context.
Okay, at least we've gotten it from a structural perspective. I'm thinking now from a patient, caregiver, kin perspective. One, when to seek a second opinion and how to. When I think let's begin there. And then what is the recourse in the event that misdiagnosis has happened?
So first, a second opinion, third opinion is a good thing. We actually encourage it. You know, if I've told you ABCD, it's good to seek a second opinion, and maybe you'd have your friends who are doctors. I've been told ABCD.
It's also a privilege, and it's
not a privilege. I'm saying a second opinion. A lot of people do seek second opinions.
It's expensive. It's a privilege of someone who has a medical cover, or someone who has the money to pay out of pocket
or
to go
has
to Dr.
access to another facility,
and then Dr. Latif, and then Dr. Mariam, and then Dr.
It depends
Kigondu.
now what you're defining as a second opinion. I think
from
a
two
second
medical doctors. Consultation 1 I've paid, consultation 2 I've paid, or I pay for insurance, therefore I can go for consultation 1, consultation 2. That's expensive, doc.
Yeah, but that's rare.
Oh, so.
You see, that's
rare.
That's rare.
What's
There,
rare?
if we of 100 clients, and again, you know, these are all different. Of 100 clients going to a hospital, how many will probably
Seek
seek
another
a
opinion.
second opinion? You get? So it's rare because the system is already, if you have gone to the right place, so to speak, is already designed to get you well and you get.
And I think that's what Mariam is saying. It's rare, not necessarily because people do not want to seek a second opinion. It's because people will not afford to seek a second opinion.
And no,
And
it's
people
rare
would
because
like to seek a second opinion.
No, it's rare because when you go to be when you go for treatment, you're likely to come out well. You get and the issue with health things, they are repetitive throughout your life. Let's say you live for 100 years. How many times will you have
A cold.
not a cold? Will you have seen a health practitioner? You get, but there's that one time where you say, but there's that other million times. You get the point. My point is this. It's you need to analyze. Not from a blame point of view. Actually, this is the bottom line. You need to analyze from a improvement point of view. And this, for a long time, and health has not picked this up, but for reasons that you have having many players like patients, is the aviation industry. When Concorde fell, they didn't say the pilot flew into a cloud. You get, they went and looked and they said,
What was the
this
problem?
thing
What
dropped. But
caused?
when this thing dropped, why did it drop? They go back and say a guy did not screw. You get what I mean? But it's very easy, by the way, to say Concorde, the pilot, you get. So for me,
I'm thinking about it from a welfare perspective, not a blame perspective. The welfare here being the welfare of the patient. So when should you seek a second opinion? It's not a blame thing. I think the thing about this topic is doctors are very sensitive about it. So it becomes hard to also approach it because you're just asking when should someone seek a second opinion? And it seems hard to get a straight answer for that.
no.
Okay.
Actually, again, in the World Medical Association policy document on medical errors, and I'll quote for you, many physicians fear being unfairly blamed for medical errors which may have been caused or exacerbated by systemic factors and often feel unable to open or raise concerns. You get the point. So a workplace culture of learning, and this is what we are trying to drive us, assures and improves patient safety, embedding a just and learning culture. We have been in this system. I personally have been a doctor for 25 years, and I have seen the system change. Of course, when something goes wrong, it's always the doctor. But we've realized that why that answer will be the same 25 years from now will be because you have not put a system that when this happened, what was the issue? And then you do a continuous improvement. A good example is what is called maternal and perinatal death surveillance and response, what is called MPDSR. MPDSR is a mother has died as a result of pregnancy. Why? And therefore, so you start why. Of course, there are factors that, okay, these ones may feel aggrieved. You can take that to the board, that will be sorted. The indemnity may kick in and do compensation because now you can't bring back this person.
Again, you're going to after the fact. I think our question here is, as a patient going to a health facility and I'm given this diagnosis, when should I seek a second opinion? And why should I seek a second opinion?
I think Janet...
Before we even go to what it's a misdiagnosis. We are not calling it a misdiagnosis.
We're saying,
I'm just saying I've gone and I've met a clinical officer or a medical officer and I've been told this and the other. And I feel I'm not satisfied with what they're telling me. When should I seek a second opinion? Why should I seek a second opinion? Or what can I ask this person so that I feel satisfied? Because the reason I'm going seeking second, third is I'm feeling I'm not satisfied with what I've been told.
So that's good. First, a second opinion can be sought at any time. And Janet brought that up when she said, I went, I was treated, and I didn't feel. And that's reason to bring a second opinion. Secondly, a second opinion is, why are you seeking a second opinion? You're seeking a second opinion because, one, you said you did not feel satisfied with the explanation. That doesn't make the explanation wrong.
Yep.
You get, so, but you just think, no. Yeah, so, and there are various issues. Maybe this doctor communicates better than another doctor, or this time issue. You get, once you take this medication, then in 24 hours, but still you're not feeling that. So you can seek a second opinion. That's not. Then thirdly, is if you don't get better. You get, as in the symptoms are continuing and or the disease is continuing, then you seek a second opinion. And even at the first instant, if a doctor, if a doctor thinks that, yeah, atushikani, mimi na wewe, then actually tell you, Janet, you can go to doctor, you can even recommend another doctor or ask the client to actually seek a second opinion. So a second opinion is really not, again, even the way of looking at it, it's not a blame thing, so to speak. It's just that the client is not feeling well.
He's not feeling. And many times it's because the client is not feeling like you've heard them.
Yes.
Right? So why is it, and I wanted to ask this question, what's your training like? When you are being trained as a doctor, how many years in university? Before you graduate with that degree, the first degree?
There are many.
6 or 7.
How many?
So a minimum of 6,
Okay.
the maximum.
So
can
6.
Maximum
Right?
can be more.
Many.
Can be more.
6 years,
Yeah.
you are then graduating,
Yes.
but you still can't practice. You have to do the 7th.
Internship, yeah.
The
You have to
internship.
do
So then you're
internship.
licensed by the KMPDC,
Yeah.
right?
Yeah.
So 7 years
Yeah.
of training and practice. What are you taught? And why is it that people feel like doctors are not hearing them, or they feel like they fear asking questions to a doctor?
Okay.
Because
So
that's why I do not want to ask you the questions I have. I want to go seek another doctor.
Yeah.
And I start a whole story again, and I see whether what they'll tell me
Is the
is
same.
similar to what you told me.
Yeah.
And that's where the second opinion comes in.
Yeah, yeah.
I should have felt comfortable enough to push back on you and tell you, napana. Wewe unaniambia ni pande hii, si mimi nimekwambia nasikia uchungu pande hii.
Yeah. Yeah. So the first premise is that majority, again, you know, we always delve on the minority. So as a positive fellow, I always start from like, let's say 90% of my patients, let's say, will say, hey, that's a good doctor. He gave us a, but there are 10% who will say, no, that guy is bogus. I don't know, depending on our interaction, you see.
Yes.
And that is the scenario. 2, but I get also where you're coming from. The training on communication is a chapter in medical school, but you know, there's one thing to be taught, you know. There's training on communication continues when you are seeing clients and people. For instance, you are medical students, you are actually observing how your teachers are interacting. So that's part of the training. Then in internship, you are also being assessed on how you're communicating with patients. Because at the end of the day, by the way, it's not how clever you are. It's how you made the patient feel. It's how you made the
Empathy,
patient
yes,
feel.
yeah.
So as the professional may be looking at it, hey, that guy gave excellent medicine, your science, ilikuwa poa. But how you make the patient feel is what actually leads to majority of complaints. You see, maybe there was no explanation, you know, yeah. And that has many factors. Can be the character of the patient. It can be the character of the health provider. It can be the whole system issue. You see, so I agree with you. First, there is training in communication in medical school, and then there is training by observing and there is training by practice. Maybe a bit controversial. I would bring one more point, is that for 25 years, I have worked in both public and private. For 25 years, for various reasons. Now, what's my experience? The public facility is high volume, high variety of disease, you know, high, you see. So the doctor who works there will have a lot of experience, will have a lot of skill, and will have a lot of the variety they have seen. You get what I mean?
Yep.
But hakuna time ya kucheka na watu. You get what I mean? You are in a maternity with 100 guys na mama sijui, in quotes. You get what I mean? Yeah? Now, in the private sector, probably low volume, your assessment is actually on client care. I in my early days, I used to think I was very clever. So I used to come, and I was very clever. So I used to work in the private sector. Uko mashinani. Then I come to a public facility. I see clients, you know, for them. Now, one day, the CEO called me. He told me, hey, doctor, at night, a patient said that she was seen by a street man. Let me tell you. I said, what? What do you mean? Yeah, you are dressed like, you get what I mean? Like a vagabond or something. You get what I mean? Why? You're so used to working in the public sector that now when you come to the, maybe you need orientation. So my point, doctors should work in both public and private sector. And then you have your skills, now the nice skills.
So there's a diversity of skills.
A diversity of skills.
Let's take a break, continue.
Yeah.
In the next hour, we want you to call in and let's engage Daktari. Dr. Simon Kigondu is the president of the Kenya Medical Association. It's a voluntary membership association that brings in together medical doctors into it, but also other healthcare workers can opt to be members of it. And so we're talking about medical misdiagnosis, and some call it neglect as well in some cases, when doctors get it wrong. You can call in with your own experience and share, and let's also share this, and let's hear the doctor's perspective out of it. Back in a moment, it's 9 a.m.
Another story, Kenyan senators have called on the Ministry of Health to investigate the quality and distribution of contraceptives in public health facilities nationwide. This follows alarming findings from a recent study by the African Population and Health Research Center, which reported over 1.4 million unintended pregnancies in 2023. Notably, the study found that 35% of women who used emergency contraceptive pills still conceived, raising serious concerns about contraceptive efficacy.
Right.
Well, what an apt segue
What a way to
come right back to the conversation.
I know we're talking about
misdiagnosis. Exactly. Yes. I know we're talking about misdiagnosis, but can we talk about that? Can you react to that and tell us what the issue could be?
Yeah, so I think if we boil down all these issues, it's an issue of financial investments in healthcare. So one of the pillars of our healthcare system is finances, and it sort of holds everything else. Since Kenya declared that it is rich, that statement of being it moved up a tire, and a lot of donor support got withdrawn. That was as a result of you people declaring yourself rich. Our charges at WMA also increased because we also moved up, so we have to pay more for the membership. Then there's a financial gap, and a lot of the contraception, let's say, and a lot of even drugs and all were donor supported. So we are in a situation now where we are lacking a lot of things, including vaccines. Actually, that is even more serious than the contraceptive issue. So vaccines are lacking due to, and therefore the government must give more finances to healthcare. And I've seen, we discussed under the umbrella of Association of Professional Societies of East Africa, the Finance Bill 2025. And one of the issues we have seen is that the health budgets have actually been reduced. And therefore expect more babies. Okay, that's good work for us, but you get, I mean, there's more work. But this is as a result of poor healthcare finances.
Yeah, and maybe poor information. I wouldn't say it's vaccines is worse. I just think all are equally important, because if it's unintended, I like how you've said it's more work for you, but it's also just a mental and financial burden for now.
Yep.
These women who find themselves saying, I thought I'd used this. Oh, we have a caller. I was going to read some feedback on YouTube. Jackson, what's the name of our caller? Mora from Nairobi. Okay, Mora, good morning. Do you have a question for our doctor in studio today, or comment you'd like to make? Hello, Mora, can you hear us? Okay. Looks. All right, we'll just continue, but as soon as we get her, we'll ask the questions. Just some quick feedback. Steve Maguta, apart from near misdiagnosis, I find most doctors overworked, and this makes it hard for effective multidisciplinary team. Multidisciplinary team working effectively reduces misdiagnosis. ZPFQR, being poor is not a joke. You have to go to public hospitals where there's too many students hanging around everywhere with their charisma and eagerness to learn. They told us to pay for a mini surgery. We said we'll do it next week. Went to another doctor who gave us some ointment. Wow, that is misdiagnosis if ever there was one. Kikombe says, Eric, I inherited Otula from you when he went to Maseno. Oh, so the legacy continues. Okay, Mora, is that the name you're saying? Okay, Mora, good morning. I hope you can hear us. Do you have a question or comment this morning?
Comment this morning for the good doctor. Good morning, how are you?
Good, thanks.
Good. I've listened to the conversation and what the doctor has to say, but I would like to make a comment. There is, of course, genuine misdiagnosis among some doctors in our country, and it happens. If you speak to many Kenyans, you'll find that somebody has an experience of what they went through, how they went to this doctor, and they were misdiagnosed, and then they had to seek a second and third opinion for them to get the solution that they needed for whatever medical issue they had. But other than that, I think there is misdiagnosis, or there is, let me call it diagnosis for profiteering. There are doctors in the country who diagnose patients, especially in private clinics, diagnose patients in order to make profits. I'll give an example. One time, I had a really bad stomachache, and then I drove to the hospital. I got there. I was literally holding my stomach. Then I was given a bed, and then went to see a doctor. Then lab test came out. Then I was told I have H. pylori. I asked the doctor, what are the signs of H. pylori? I've never had any other stomach issues. What are the signs? How do I just get H. pylori? And then, he was like, oh, you have had to have issues with your stomach for some time before now you get to this point that we are asking you to take medication. But I'm like, I have not had an issue. But actually, by the time I was speaking to the doctor after resting, I was already feeling okay by the time I was being diagnosed. I told the doctor, then I will not take medication for H. pylori. I don't have H. pylori. I just say that. I was not sure. I had to speak to even the lab person because I couldn't believe I had H. pylori. But okay, to cut the story short, it turned out I just developed lactose intolerance. But at this point in this hospital, I was being given medication for H. pylori.
But what makes you think, Mora? Because you said in many cases you feel that the misdiagnosis is deliberate for commercial purposes. In such a case, for example, what would make you think it would be for medical purpose, for financial purposes?
I think it's for financial purposes because how do you tell a patient that they have H. pylori or they have something? You see, if you look at, even when you ask, when you get diagnosed in some of the private clinics, you're given at least, the doctor writes this medication, then if you are people, I've learned to ask questions. If you're a person who asks questions, and maybe has taken time to educate yourself, I'm not in the medical field, but you ask, what does this medication do? Yeah. What does this one do? What does this one? You've been given double of something, yeah? Or things you actually don't need. So you ask, what does this medication do? But I don't have that. What does this one do? So you end up, if you're not careful, you might end up with being over-medicated. Yes, and I think that's a real issue that we have in some of the most of the private clinics. or hospitals in the country.
Right. Thank you, Maura. I think it is very pertinent, and maybe you can, even stay on as Daktari responds. And there was an expose, and I think this was very mind-boggling for me when I found out that private hospitals have quotas, same way every other business does.
Yeah.
So sometimes they will keep you there longer than necessary to hit their quota. It could have been released today, but it's like, stay one more night. Sometimes it's, of course, how many tests do you really need? How many can you pay for? How many is your insurance covering? Let's squeeze as much out of you as possible. So, yeah, how does that financial motive play into misdiagnosis, Doc? And an honest answer, not a policy and structural one.
Are you
insinuating?
Am I
Are you
insinuating? Yes.
inserting improper motive?
I didn't want to go, but thank you very much. And the story of Maura is you'd say quite common, but we need again to zoom out. I'm a policy expert, so and first, if we are to interrogate, not that you're bringing, did she or did she not have H. pylori? You get my point. From the symptoms she presented to, maybe one of the tests was H. pylori. You see, we don't want to come from the point of view, oh, it was a misdiagnosis. No, was it not a misdiagnosis? And I can tell you from a medical point of view, you can have H. pylori with no symptoms. So if we do a stool test, and we find H. pylori, and you had symptoms of that, we could attribute it to that, but it could also be an incidental finding.
Right.
But number two, more important, is peer review. And this we have stressed as the Kenya Medical Association. Eric cannot come and decide that this institution, let's say what did that the clinician or whoever saw the patient, was it right or wrong? Was that the way to go? It can only be done by a peer review mechanism. Only Kenya Medical Association can come. We follow, we go to that clinic. We go to that clinic if there's a complaint and say, one, where is this clinic? Two, is it registered? And what is the registration form? Because we have many clinics that don't have doctors, but the person in a white coat would be interpreted to...
Mimi ndio niko.
Mimi ndio daktari, the clinician, and there are various levels. So, and the levels are classified according to what capacity of personnel do you have there. You get, so you may have a lot of health facilities in the lower levels where you may actually not necessarily, it may be the level of the nurse, and they are allowed to manage at that level and escalate the problem a bit further. If they can't, then you can go to a level where there's the clinical officers and they treat, and what they can't treat, they escalate, and then maybe you come to a facility. So the first thing we go to that facility is to assess what is their level. And two, did this particular person follow but by the way, there are common protocols, so to speak. For you to diagnose malaria, you have these symptoms, you see. Did they follow? And if they follow, now then we come to address the client issues. You get, so it's and I'll keep stressing this over and above, that you actually need a holistic view of a scenario to actually. The first thing you acknowledge is that medical errors do occur. You get, now the perception in which it comes from, then we need to provide a framework. How do you even escalate this?
Yes, and I think that's the issue. It starts from the level of, it happens to many people asking and sharing their experiences like Maura has done, and it then sits in our minds as that level of mistrust. So the first thing that a doctor tells you, and you're like, ah. So when you start doubting the professional that you've gone to seek care from, then that's a big issue, which is why I was taking you back. And I know we have King Kaka on the line, and we'll be engaging him shortly on this particular issue, and from his own experience and perspective. Take us through, I asked you, 7 years before you're given a license to start practicing. And even before you get into that med school, you scored straight A's. Let's always remember that these are the sharpest guys in our secondary schools who end up getting into med school. Okay? So it's not just someone who is trisexing. Okay?
True.
7 years of learning. What are these protocols? What is the basic when a patient comes and sits in front of you and they are presenting, they're saying, this is what I'm going through. What are the protocols to the point of diagnosis and saying, I think it's malaria, I think it's H. pylori, I think it's cholera, I think it's this and the other.
Yeah. So thank you very much even for pointing that actually these people have spent a lot of time in school, and I think that should translate to payment. Normally they say it's a calling.
It's
It
true.
absolutely should.
It's
but
true.
not
But nevertheless,
for
a lot of time has
But it
actually
absolutely should.
been spent studying so that by the time you come, they have all that knowledge sort of in the head. Then the second thing is now the reason for internship, during internship, people actually work. I think I would not pay anything to go back to internship. It is a lot of work, but it's supervised work. You get what I mean? So you have actually got maybe your 100 patients, and you present in a ward round. So me, who has now gone up a bit level, I come, I listen. The mother came, started feeling pain here. I gave her antacids, and then all of a sudden she convulsed. I said, very good. Now she was admitted. I said, now those are typical signs of eclampsia or severe preeclampsia. Then they learn. You get what I mean? And even when they came and they convulsed, that intern would probably have given a call. Now,
Which
the
is why
process of medical...
is why do you let students to attend to patients? Are we specimens?
let me tell you. Let me first give you a secret.
And someone else has spoken to the number of students.
Yeah, let me give. Yeah. They really, you really need. We'll go back. Those are three different issues.
Okay.
A health facility that is training. You get what I mean? Let's not call it medical students. Is one of the. It's where you're likely not to get a medical error. You get, because the level at which you are seen, you're actually seen twice. You get, and that's already, as you are putting it, second opinion without it being second opinion. You get what I mean? So I mean, we were all interns as students.
So there's the intern, who's by then is a graduate.
Who is a graduate, yes. It's not, you know, even that branding. And even as you go further, you know, even as you specialize, you are zoomed into one zone. You may not even be able to. They're generalists, by the way.
What do they call them in other places? Medical residents?
Yeah.
Now, residents, the next level. That's when you are doing postgraduate training. Like I was a resident.
We can pause and take a call. Huh?
Yes, please.
Yeah, take a call. Yeah.
Okay.
Yeah.
Do we have King Kaka online? Okay. Hi, Kaka. Thanks for calling in. I know you talked about your story extensively in the media. Just talk to us a little bit about what you were dealing with, and especially that element of misdiagnosis, because that's the conversation we're having today.
Beautiful. How are you guys?
Good.
Fine,
We're
thanks.
good.
So I think I've mentioned it a couple of times. Mine was, I just went into the hospital with a small problem. Mine had like a fungal infection, kwa throat. And I thought it was just a walk-in. Now, if you have a fungal infection, kwa throat, now you'll start going to these big hospitals. Unaelewa?
Yeah.
So I went to one of the hospitals here in Kitengela, because that time I used to live around there. And even I knew some of the doctors. That's how intense that thing was. And I was advised, this thing is easy. We just give you antibiotic shots, since you can't take oral medicine, oral tablets. We just give you shots for 6 days. I don't know, 5 days. My option was they admit me, and I was supposed to get at 6 a.m. every 6 hours, four shots, right? Then I think at some point it got better, and I was like, oh, cool, it worked. So like after a few weeks, my body started acting up, and I could not trace it. I was like, what's happening? And months, and I started losing weight. I lost 33. I almost died, man. So when I got this other doctor now, because now it was a matter of life and death, So this doctor told me, we need to trace what happened. When was the last time you took medication? Because now your body is eating up itself. And we traced back. And funny thing, I was told, because I usually take any medicine that I take, I usually take photos. If you recommend me something, I take photos. So I had taken that particular antibiotic. And this guy tells me this thing is actually outdated. Actually, part of the medication was outdated by the government. I was like, why was I given this thing? But then it was too late, and it got to that point. I know I should have gone to the point of suing the guy and whatnot, but I was in a forgiving space. So I just called him while I was in hospital, and I told him, what you did was wrong. Don't do that. And that applies. Even my mother last year, we've been through a lot with her health, and someone had misdiagnosed her, and we've been treating that for a very long time. So last year we got someone, and they told us stop with all that medication. She'll be okay. Now my mom is up and walking, literally, she's almost running. She was bedridden, and it's crazy. So I think.
So it's a medication that was making it worse.
Diagnosis, and it's crazy. Yeah.
In your case, Kaka, the medication, when you say, was it expired? Was it it's banned or no longer in use? What exactly?
I was told it's no longer in use. So how comes, even the doctor was shocked that I was given that medication. It's like, what? They gave you this.
Right. So it treated the infection, but then also gave you now.
Came with new problems.
Yeah.
And I could not even trace back to what I was given. I was like, I don't know where. Because all my tests were negative. And this doctor told me your body is eating up itself because the cells are now, it's the result of what happened.
Right. Pole sana Kaka, I'm glad you're doing better. Definitely, we're all glad. Is there something you think from the chain of, who holds responsibility in this case? Because someone prescribed the medicine, someone diagnosed you, someone dispensed the medicine. There's also the people who sold that medicine to the pharmacy that you went to. So who holds responsibility here?
I feel there's a whole syndicate. There's a whole syndicate going on because we've had so many, and I know most times I'm usually against the government, but this time I might be right because
I
might be 100% right, because if someone authorized the importation of these drugs, and they knew this was either in stores for this number of months and is expired or whatnot, how comes they are distributed and they are in use?
Right.
So someone was making profits off them. And Mefika time, even doctors are just excited about how many patients can I see in a day. Now they've turned that thing into a business. I know it's a business, the lucrative one. After meaning it's almost for 7 years, man. But I feel like the reality is that kind of profession requires, it's an act of service as well. Yes, you charge your consultation at kama 10K, but make sure now, because I'm trusting you with my life. And the people kuna watu wengi wanategemea ba.
Thank you,
just
Kaka.
do what you studied for.
Right. Thank you, Kaka. Let me have the doc respond to that, because that's the element we've been trying to bring in. These are people's lives, and there are structural ways, of course, for redress. There errors do occur and all of that, but at the end of the day, I think a big part of the issue is that a lot of patients don't feel listened to, or feel that they were neglected in one way or the other. That's the real crux of the problem here. If it was errors of other sorts, I think it would be much easier to say, you know what, we have a good medical system and we have medical care that is to the highest possible attainable standard. But when people are saying, I don't feel like I was heard, or I should have raised the alarm, or this shouldn't have been on the shelves, it speaks to something deeper, to beyond an error and to more a systemic problem, which you have spoken to. But now how do we arrest it? How do we deal with it, Doc?
Okay.
You can also respond to Kaka.
Yeah, so I'm hoping that he can still sing. Unaweza imba? I hope you are treated well enough to be able to sing, kwa sababu tunapendanga mawimbo zako.
Sayata nimenona.
Very good. Excellent. But just to, again, if I'm hoping by the end of this show, people will see the whole medical system. And as I began, I said, it's an orchestra. Kuna watu wengi ambao wana, they contribute towards your healing, so to speak. In the case of that has been presented there, then what we would normally do, we have seen that something happened. And then from what King Kaka is talking about sounds more like a reaction to a specific drug. There are some drugs known to cause reactions, so to speak. And those are reportable items. Like if you react to a drug, you should actually report to the Pharmacy and Poisons Board so that they go back, trace the batch or whatever it is, and see what it is. So an investigation would really be useful. Then secondly, we normally we don't specific cases are dealt with specifically, and you outline what the issues are. So normally what happens when such things happen, they, as I have heard, zoom in, you can charge consultation, that. So the blame, again, you get what I mean, is squarely on the doctor. The reason blame always goes squarely on the doctor is the face of the system. He's the one who is in contact with the patient. He's the one who is the direct. You can easily blame that person. And it is possible there may have been an issue. But
and it's the one who's making the direct decision on the patient.
On the patient. I have a quick question to ask this so that we can let Kaka go. He said he didn't report or sue. He was like, that's just going to be time consuming. He just called the person who administered the drugs and said, don't do that again. But in a case like his, what kind of recourse is necessary? Is there any charges he could press? Is there some kind of, is reparation the right word, that he should get? Like what should happen in a case like this? He's chosen not to pursue it, but...
So a client might feel aggrieved. The process of doing that is actually lodging a complaint with the Kenya Medical Practitioner and Dentist Council. And the Kenya Medical Practitioners Dentist Council has representation from all over. Kenya Medical Association has one person in the board of KMPTC. And they have processes. You get something called a preliminary inquiry committee. They ask the hospital, send us this whole file. They go through it and see what was done. Then the second stage, they may, if they see is issues, then they also get the complainant to give a case. If they think that this one needs them to go to the facility, they would go to the facility, inspect, see whether everything is in place, and then finally, some form of resolution would be made. Some resolutions like, okay, everything was done well. Sometimes some clients don't feel happy with such a decision. The others which may need reparation, as I told you before, there is an indemnity aspect, which we have identified that, sometimes you may need reparation, but not necessarily because this person mismanaged you or went out to mismanage you, but it happened. You get, and that's where indemnity comes in.
Okay.
So it just comes back. I think for me, I'm looking at it from the point of, you've heard from Mora, you've heard from Kaka, you've heard from Janet, you've heard from very many people, I'm sure. As a doc, wherever you go, people tell you, but. There's a deep issue here that we need to address, right? Okay. Which is, I'm going back into that one of, why would we get to a level where you see one doctor who went to the same medical school, who went through the same procedure of training, and they tell you you have a stomach issue. And then you go to another doctor and they tell you you have a head issue. Is the problem me? Is the problem the system? Is the problem the doctor? Because everybody just gets lost on that. Or that one where you're told, take this medication. Another one says, stop taking the medication. And you're fine. So, I mean, what was wrong? Is it that this one got it wrong by saying take medication? Did they should I now be questioning everything? Should I come to a hospital and ask you, okay, where is Susanna?
So I actually have documentation to your head, and let me do this in 1 minute. And the way I started, the factors of medical errors can be patient factors, provider factors, and system factors. Let me just go quickly through the patient factors. Incomplete and inaccurate information. Garbage in, garbage out. You get giggle. Yeah? A patient may unintentionally, you see, you also don't want to say, withhold information due to memory gaps, fear of judgment, stigma, and lack of understanding. This will lead to an incorrect conclusion. You get? That's one. You've done. The second one is atypical symptom presentation. You see the way you're saying, So conditions like a heart disease, for instance, appendicitis, they may present differently across different age groups. You see the typical, uchungu hapa. Some people may come with actually eye pain and it's appendicitis. And these increase the risk of an error. You get? And therefore, that goes to the mutu lazima awe. You know, the eye sees only what the mind knows. You see, so there may be someone who is more
the level of experience,
and also time. You get what I mean? Today, this symptom is this, then it progresses to that. The third one is cultural and language barriers. This can lead to miscommunication about symptoms, pain levels, expectation of care affecting diagnosis. You remember our fight against Cubans? One of the things we said is that the Cuban in Kegumo, a Cuban, you get so you have
that's malaria. That's code for fever.
Correct. Now to interpret, you get this guy interpreting. That was one of the things. Then there are health-seeking behavior. There are those who delay in seeking help. The key patient for that particular one is that patients play a vital role in the diagnostic process.
And we'll come to that. I think we have a caller and we don't want to lose him, but it's very important that we come to the patient's responsibility. Edward from Embu, good morning. Do you have a question or comment this morning?
Yeah, good morning.
Good morning.
Yeah, so for mine is a comment and also I would say an observation. I've heard the study talk about the statistics, the data that's out there with these medical errors. I think it's actually a gross underestimation, considering how we arrive at this, because you realize that for it to be considered to be an error, it must have been agreed. But you realize that most of these situations you find there's a lot of cover-up, especially when the medical personnel realize that they've done a mistake. You then realize there's so much cover-up. I've had an experience where there's a procedure, there's an error that has occurred. Then later on, before there's an attempt to try and, cover up before, all these things are done. So at the end of it, when you're talking about even this peer review and everything else, people fear so much. In the medical profession, people fear these, medical legal and such. So at the end of it, there's so much is underestimated. Only what comes to the surface is what you're able to see. But there's so much that happens. And now in our current setting, you realize that the patients or the clients are, from a point of underprivileged. And some of them don't even know how to go about this. The process is so long, going through KMPDC. I know a case that has been followed for close to 2 years, even getting on the table at KMPDC. It's not even been able to take place because the medical personnel also take advantage of the loopholes that are there in law. to try and delay things to the point of frustration. Now you've lost a patient, you've lost a loved one, and you're still going through the pain of trying to, for the system to just accept that there was a mistake that was done. And it's taking so much of your time, and you're also going through these, emotional issues that the whole process, has made you go through.
True. Edward,
So
let me ask
quite-
you, as we come to the
Yes.
back to the doctor,
Yes.
what would you recommend? What from where you sit, what would you like to see done better?
Yeah, for me, I would recommend that no one wants to go through this blame thing, but again, it's better that we accept that this is what has happened. He talked about the peer review thing and also, review by KMPDC, but even those who are in there are so much afraid of this. No one wants to tackle what's going on. One thing I can say is like the training currently for medical personnel, it's so haphazard in the country. I had mentioned earlier on that, these are the big brains, they've gone to school for 7 years and everything else. But right now, look at the landscape. Everybody is training medical personnel. And, that straight A that you talked about earlier on, it's not the case anymore. You have people who, B plane, B minus, and all that now being trained as medical personnel. And these are the ones who are now causing a lot of this trouble, according to me, if I can say, because a procedure is supposed to be done. For example, there's stipulated way of doing it, and then you see people taking shortcuts, and at the end of it, somebody's lost their life. They can't be brought back. Even if you talk about reparation.
Right. Thank you, Edward. Just
So
to be
it's
clear,
a very big mess.
Edward, are you a medical practitioner?
I have some inside information. Yeah, I don't want to disclose that, but I have some information about how a little bit of how the system runs and everything else, even the training aspect of it. So it's such a big mess. I don't know how we'll get out of it.
Thank you.
We talk about statistics, but now when it touches you, that statistic is part of you. You can feel the pain. It makes you even not want to go to a hospital anymore when you're sick because you're just wondering.
That's true. Thanks, Edward.
Thank you.
Yeah, let Doc respond to that. And I think Edward is absolutely right. Even from personal experience, if you go seek a second opinion and a doctor tells you something different, but they will, like if you say, oh, I've been misdiagnosed, they'll not be like, yeah, you've been misdiagnosed. They won't say straight up.
They shut you out at that point.
Yes, and
Dennis
they'll tell you
says,
this is what is up, but they won't say that the other person misdiagnosed you.
Made a mistake.
Made a mistake.
And there's also the issue that Dennis is raising. Before an average Kenyan finds a specialist, he or she will have been misdiagnosed by several clinical officers or doctors in general hospitals. My aunt got a proper diagnosis too late. Sharon says, I was misdiagnosed, at least at the time I thought I was, but later I learned it happened. I traveled to India for a proper one in January 2013. I'm glad that I did.
It's my sister.
This is your sister,
Yes,
Sharon.
it's my sister's story. Heart-wrenching what we had to witness. It's a very real thing. And the way Edward has said, it goes beyond the data now when you're seeing it up front and up close is when it really hits you. And then there's that paranoia, like can I trust the system again? Because for hers, I think it was a misdiagnosis maybe 1, 2, if not 3 times before saying
Before
the correct
diagnosis, yeah. So you can speak to Edward, Sharon, Dennis.
Yeah. So first, let me speak to the trainings. There's been an outbreak of training in quotes. Medicine seems to be, lucrative. Not necessarily so, but the training of it. Yeah. So it is important for the government to rein in on these training institutions that claim so, and that's regulation. The second one is on the conflict between, and now when we go to medical doctors, the Commission of University Education, CUE, and KMPDC. Their relationship fractured when the CUE changed their laws to ignore the input from the medical practitioners. So KMPDC says that your university has a capacity to train 100, but you admit 400 for purposes of money. You get what I mean? And medicine being the highest charged training, in quotes, you get a lot of money. So that there has been a big problem, and we've been trying to fight to change the law such that before you admit this number of students, KMPDC is supposed to do. So that's part of strengthening regulation. So that I think we need to continue fighting on that, so that you are not admitting too many. Those ones, you had the complaint that, oh, there are too many medical students, so to speak. But that said, again, I would say there is need for continued training. A hospital, which is a teaching hospital, you are getting third, fourth opinion. In fact, those students who come to check, it's very nice. They may pick something that was not, so it's almost like multiple examinations. So also that's the other side of things. Now to the issue of, maybe to speak philosophically, so to speak, Kenyans should own their health system. So the frustrations come from an inability to complain, as you put it. Where would you complain? So for instance, at a local level, you get, then we need to have a strengthening of, they call them, the current government is using community health workers, community health promoters. At that level, there should be some form of mechanism of escalating a complaint, you see, at the lowest level. So, of course, now, and I had, was it Dennis who talked about KMPDC? By the time you're reaching KMPDC, that is far. You get what I mean? So there are local mechanisms. I know facilities, and I ran a facility for, I was a medical superintendent for 5 years at Isiolo District Hospital. And one of the mechanisms we put back of improving communication with the client is that we put a telephone number in casualty there. If you have any complaints, you have waited for too long, then do these numbers. And we used to actually get feedback, and you get instant feedback. Like someone would say, oh, I've come here, there is no one to see me. You get that would be get acted on. So we as Kenyans need to look to have local mechanisms in which the issues can be raised at the lowest possible level. So the facilities should have that mechanism clearly put at that. Then that also now you may have the county facilities also having another second tier, then now at national level, which is the regulator. So over and above that, I think a lot of the issues would be escalated from the bottom up, literally, because by the time they reach up, people feel unheard, because again, as people said, not everyone would have access to that reporting mechanism. So it's actually upon health institutions and government, so to speak, to give an mechanism, just the way we complain about government, and you are feeling that you haven't complained loud enough for them to change. There should be a mechanism that moves from the lowest level to the highest level. But that said, we need to strengthen regulation. We actually need to give teeth. For instance, recently, funding was withdrawn from the budgeting money given to KMPDC was withdrawn. The government said we are no longer supporting funding. And yet KMPDC are the same people who are supposed to go and supervise. Without funding, how would they do it? How would they do their work? So it's important for us to invest in the regulation of healthcare. As a medical association, for instance, as Kenya Medical Associations, we normally put out, we are actually the voice of the people, because we have no, how do you put it? We do not have, we are not interested, we are not the ones running the facility, for instance, and we are out, it is the patients who complain to us. We get the brunt of the complaint. So sometimes also having a louder platform and voice to be able to be heard is easier. I can complain for a patient more easily than the patient can complain, and I can actually see that. So we need to strengthen the professional medical associations to be able to speak for mwananchi. You get, at the end of the day, you want the mwananchi, and that goes in line with our theme of advocating for the highest healthcare. So when we say the government has not done this, you don't bash us. you support. The government has not given money for this, then you support.
I think Kenyans, in general, we do advocate for doctors. I think we're, very much behind you, even during strikes. I don't think, there's any level-headed Kenyan who would say, no, don't pay doctors that much. But just as we wrap up the conversation, something that I had said, let's discuss this at some point during the conversation. Tech and AI going into diagnosis, what effects do you see, positive, negative? And is there a danger of bias? Because with tech, there's always a bias of where the data comes from, what it's fed on. So yes, if it gets to a point where I point my camera at my skin trying to diagnose something, it could be like, I don't really know what that is. Maybe because they're not used to skin that looks like mine.
Yeah. So you bring up a very important point in time. So as we have said, as you saw, some of the World Medical Association policies keep changing. One of the reasons they change is now you have tech, for instance. So you have to update the policy to a place where you're also incorporating diagnosis by artificial intelligence. And so what we can say is that doctors will not be replaced by AI. But those who will be replaced by AI are those who will not use AI to enhance their skill. AI is fantastic. It collects the whole world and helps you with diagnosis. What we would probably have, we read in many days in school, then now that's it. So AI should actually be used to help reduce misdiagnosis, and because it also brings the collective together. So anyone who uses AI, the doctors are encouraged, and a lot of training is coming onto that. Tech, now answering Dennis, one of the issues that he raised is documentation. So the government, and to their credit, is moving towards what is called an information superhighway. And the health system, then you are seeing how do you promote electronic medical records. And with that, and I having transitioned from paper to electronic medical records, and you can use Murang'a County as a SI unit of, we are paperless in Murang'a County, then it becomes easier to analyze all that you have said. You get what I mean? So for someone saying, oh, they're hiding, you get, previously you could hide because the file, ni kama hizi files za police, but now
page can be plucked out.
Your page can be plucked out. Now with systems that are getting improved, then you're documenting into a system that is accessible. You see, that is helping improve credibility, so that mtu aseme, oh, they're hiding. No, they're not hiding. You'll just be given that. And that has really helped, especially in our maternal and pediatric surveillance death reviews. You say, oh, the mother died. Then you bring the notes together, analyze, oh, what went wrong? What are the improvements?
I think I'm very worried. Oh, sorry, Amariam, go ahead. I was just going to say, I'm very worried about that space of maternal. It's like a death sentence now. And I know that sounds exaggerated. He's even like alarmed. But every other day you will see, I don't know whether it speaks a bit to medical gaslighting is not to throw so much blame on professionals. You've come and you've explained yourself really well, but then it does exist. I think there's some data that says 90% in some countries of women don't feel like that their symptoms were downplayed. But it's now leading to increase to many levels of, maternal health cases. And even then, there isn't much of a follow through or an effort to either extend empathy or to admit and say we need to do proper research on it. I'm just worried about that department. Even online, every other week, you'll see a story come up about somebody saying this happened to my sister, this happened to my wife, this happened to my daughter. And usually there's like 2-3 characteristics. She doesn't feel like she was listened to. She feels like the doctor downplayed what she was feeling, which speaks to the gaslighting. And then it led to irreversible harm, in some cases death. Sorry if I interrupted you. You just mentioned it.
No, that's fine. That's fine. So maybe as a parting shot, is this my last line?
In 30 seconds.
It's my last line. Misdiagnosis is rarely the fault of one person. It reflects a gap in communication, that's Eric's favorite place, training, trust, as you put it, and infrastructure. So solving this requires a shared responsibility between patients, providers, and policymakers. And only by addressing all these three can we ensure timely, accurate, and compassionate care. And Kenya Medical Association is there to help in all these issues.
Thank you so much. I think we have to wrap up the conversation there, but just from my cursory research, I think it's important that, we have information as we go out into the world. So in the event that you're, going through something and you do visit a hospital, one, like we've said, it is okay to seek a second opinion. It's a factor of privilege, we're very much aware, but where possible, and especially for serious things, do try and seek a second opinion. Like even Doc said as well, a second or third opinion is perfectly fine. I think advocates always have someone with you, if possible, someone to advocate for you throughout the medical process. Also, as we move towards this information superhighway, keep all your medical records, including any objections that you made that you feel were not heard. Ask that they are written down, and you put those down for the sake of memory and, for any future notices or anything that may be noticed in future. So do make sure that you keep all your records as much as you can, and objections as well. It also helps someone to question once or twice, but also don't feel bad about pushing back. I think we have this, thing where we look at doctors as, I'm a bit scared, but no, they are there for your treatment. So push back. If you don't feel heard, he's also given us the mechanisms for going through that chain of command.
I like that. So well summed up. Brilliant. Yeah. Thanks for that, Mariam. Thank you, Doc. Did Doc feel like he was in the dock today?
You've been waiting.
I've been waiting my whole life. But thank you, though, for coming and making clear, and to all of you for engaging us on Fixing the Nation. One conversation at a time. That's what this is. It's not a quick fix right now, but it's hopefully you have enough information, you're armed with enough information for the next time that you're pursuing whatever it is that you want to seek. So I hope we've given you some information. But yeah, Mariam Bisha, Eric Latif, Janet Bogwa saying thank you very much. You can find these conversations as well online after this show. And we'll see you back here tomorrow. Have a good one. Unaenda wapi, Latif? It's okay. Tumeanza, but we'll take this domain off air right now.
Lakini next week, I'll be joining in live from a place called Tallinn. Tallinn. Google that.
East Europe.
Yes. East or West Europe, but new.
So msianze kuuliza Latif ameenda wapi? He has said he'll be with us virtually
for
about a week. Yeah. Thank you very much. Have a good one.